Just what is diabetes? Probably something that a majority of us would confidently say we know, because, well, at some point in time, also in school, we're taught of the same. And because we'd have that feeling that we understand some more, we're just going to brush through understanding what diabetes is. But importantly, base our focus on, the burden of the disease, and especially how we're able to deal with it as a people, at the level of rural areas. And we'll be having a specialist that is going to take us through the same. The World Health Organization estimates that the prevalence of diabetes in Kenya is about 3.3% and predicts a rise of the same to 4.5% by 2025. However, 2/3 of the diabetics may be undiagnosed, and it's really important that we get ourselves to that point of understanding. I mean, could you be going through difficulties that you probably have not, sought medical advice, and you have no idea whether it's got anything to do with diabetes? And I mean, the difficulties that you're probably going through after you with diabetes, how are you able to manage the same? Is this scenario reversible? All this we get to learn right here on this particular segment. I always call it my favorite segment because with it comes a lot of knowledge, and therefore we welcome you to interact with us. #Morning Cafe at Linda_Lela TV47KE. Tell us your view on matters diabetes. If you have a family or friend who probably has a diabetes, how are you managing, or how are you helping them to manage? If you have been diagnosed with the same, how are you taking it easy to make sure that you're able to balance yourself so that you're having a healthy lifestyle? So joining us for the conversation, Dr. Stephen Ngige, who's a general doctor, but today we focus much on diabetes and the great things that he does in his own facility and entity to make sure that, people are able to stay afloat, especially at points where they've been diagnosed. And we always say some of these conditions are not death sentences. If you're able to manage them well, the advice of the doctors, eat well, then definitely you'll be able to live a normal life. Dr. Ari, good to have you.
Good to have you too, Rita.
Thank you so much for creating time.
Thank you.
You've come all the way from Murang'a County.
Yes, I'm based in Murang'a County.
Yep.
I'm a senior medical specialist, a deputy director of medical services, and coordinates Beyond Zero as well as Tiba Mashinani.
Nice.
It's a universal healthcare horizontal integration of health at the rural areas.
How much has this penetrated? How much has it come in handy to make sure that at least everyone has access to, healthcare for that matter? Because it's not been all rosy, especially on these sides of Nairobi. And so I can imagine what more for the people who are in the rural areas.
Yes, for the rural areas, especially in Murang'a County, we have formed community units. For the diabetics, we have got what we call diabetic support groups, which we coordinate with our diabetic nurse, our nutritionist, our dietitian, and myself as a family medicine specialist or primary health care specialist, because we have observed that the biggest challenge with diabetes is poor glycemic control or poorly controlled diabetes. People may have been diagnosed with the disease, but they are not able to adhere to medications. The reason being for probably the socioeconomic factors, especially in the era of COVID-19, as well as the distance from the health facility. Hence the need to pursue the community-based primary health care strategy, where we go with teams of specialists in various designated points, either in churches or schools, where we are able to meet with these people, especially the elderly diabetics who may have a problem coming to the hospitals.
Is this just for diabetes or other conditions as well?
We had all other conditions. I'm a generalist specialist, primary healthcare specialist.
Right.
So primarily what we do in the community, we give them health education. We also interactively allow them to tell us what they want. It's a demand-driven approach, and we screen them for diseases such as diabetes, hypertension, arthritis. We focus also on cancer, the common one being breast cancer and also cervical cancer. And this enables us to pick out those diseases at the early stages before there are complications. And then we are able to refer these patients with our ambulances to the hospitals, where we further on manage them if they have complications or if they need further interventions.
Yeah. How much of at the rural areas? And when we're talking about what it is that you're doing, is this specially, you know, formulated for the people of Murang'a County, or it cuts across again? Are you working with other entities, with the government, like you say with Beyond Zero, to make sure that, you know, this cuts across the different parts of the country?
Yes, we do see patients coming from all other counties. First, because they see us talk about it a lot on TV, and also because other patients who have benefited from our free outreach medical care, as well as free surgical inpatient care, go and become our ambassadors. So they usually go and preach about what we do. So we see patients coming as far as from Homa Bay, as far as from Mpeketoni down there, as far as from Nakuru. Like if I see them coming all over, because what we aim at is making sure that the service is delivered promptly. One of the biggest concerns about our patients has been delay in care, even after being diagnosed with a disease. So that is the one we are addressing. We have what we call a rapid results initiative, which I coordinate to make sure that patients are treated based on something we call Geba Kaizen, meaning that immediately they come, they are treated on priority basis.
All right. What are there to make it vice versa, in the sense that, you know, instead of patients coming to you, then you'll have managed to traverse different parts of the country, or maybe just to have stations and facilities across the different parts of the country, such that the access will be way easier in comparison to them, you know, traveling all the way from, say, Homa Bay coming to Murang'a?
We are training more doctors as family primary care specialists, and we have a large number of them basically in those. The West is largely covered by the primary health care specialists, trained in Moi University School of Medicine. We have them being trained in Maseno University, Aga Khan University here, Kenyatta University School of Medicine. I usually assist in their training. They usually come and rotate in Murang'a County, whereby they learn the day-to-day workings of a medical superintendent, because I also superintend in Maragua Hospital, as much as what we do in the community. Because there has to be a link between a health facility and the community. People have to feel they own the facility. People should not look like strangers when they come to a hospital where they feel they don't know the healthcare providers. They feel much better when they meet us in their church, in their neighborhoods. We are giving them free treatment. So when they come to the hospital, they are more confident, and that enhances adherence to medication for diabetes and all the other disease conditions. Okay.
All right. One would argue that it's been extremely expensive for the government itself to manage such, you know, free outreach programs for the people. How are you doing it?
I don't think the issue is the cost. I think the issue is the willingness to bridge the gap between the communities and healthcare service providers.
And therefore the government is not willing?
We are saying the healthcare providers are most important. And one of the training strategies that we are using for our postgraduates who are doing family medicine is to make sure that they are participating a lot in community-based healthcare services. Because what we have observed, when people are trained in one end, and then you are taking them to the community at the tail end of their training to work there is a problem of integrating them into the community. So they need to be orientated into the areas where they will work when they graduate. And therefore, the strategy of family medicine, actually a national government policy of training, aims at ensuring that people can access a primary healthcare specialist promptly at the community level, who is well trained and capable of identifying a potentially life-threatening disease condition, which could maybe have been missed if we left it to the other lower cadres who have been manning the health centers, the dispensaries, especially our clinical officers and the nurses. So we are doing that. We are supporting them, and we are making people understand that it is called a paradigm shift in the approach. It is the reverse referral, where people in the villages are able to say, yes, better including in primary care specialist, and he was able to diagnose me with the stage disease, diabetes.
All right, that's fair enough.
Yeah.
For that, now main focus is on diabetes,
Yeah.
and we probably would want to couple it with understanding
Yes.
how much
Yes.
of strides we've made as a country.
Yes.
We probably start from this basic level,
Yes.
because you know when you're discussing matters health, it's always very, very important that we start from just what is diabetes. I remember my high school moments where we could speak of diabetes mellitus, and all. But you know, sometimes it's just for purposes of reading. And once you move to the next step, unless you're diagnosed, unless your family member is diagnosed, we tend to live care, you know, a lifestyle that is full of, you know, everything. That some of these conditions can be actually instigated by the kind of lifestyle that we're living.
Certainly, diabetes, we say it's a biochemical abnormality in regulating the glucose levels associated with persistent high levels of glucose, what we call hyperglycemia. By WHO standards, if we do random plasma glucose level of a patient and find that it is more than 11.1 millimoles per liter or 200 milligrams per deciliter, we tend to say that these people are diabetics. We have several types of diabetes. The juvenile onset, the one that sets up early in life, or type 1 diabetes, is associated with complete lack of insulin, which is supposed to be produced by the beta islet cells of Langerhans. What happens is that there is a T cell mediated autolysis or destruction of the B cells, the beta islet cells of Langerhans, leading to decreasing levels of insulin. So in those patients, when 80 to 90% of the beta islet cells are destroyed, they now start having what we call complete lack of insulin and then persistent hyperglycemia. This is the category of patients that we see between the age of 7 to 25 years, juvenile onset, and environmental factors have been attributed to be the triggers for the T cell mediated autoimmune destruction of the beta islet cells. Some of the environmental factors that we think about are some viral infections, early childhood viral infections. The ones that studies have implicated include something like Coxsackie B virus, rubella virus, and another one we call CMV or cytomegalovirus, which can trigger the T cell mediated destruction. There are stages of that type 1. We have got the preclinical stage when the patient is asymptomatic. Then they go to the honeymoon period, whereby the beta islet cells which have been destroyed try to regenerate. But because of the persistent T cell mediated destruction, when 80 to 90% of them are destroyed, then the patient becomes a diabetic.
All right, so when you're saying they are asymptomatic at that level, when tested, I'd love for you to take us through what it takes for one to be tested and be diagnosed with the same. Are they of course considered positive, or it's a whole different thing?
Usually for type 1 diabetes, I have said that when we go and do a plasma glucose level and find it is more than 11.
Now that is the test aspect.
That's the test.
Plasma glucose.
Yes, but most of them will present with what we call polydipsia and polyuria. Because what normally happens when you lack insulin is that the liver continues to produce glucose. The mechanism by which it does increases when there is less insulin, because there is no negative feedback effect. And then there is also the release of free fatty acids, which are converted to ketones. And these ketones are the ones that are secreted in urine. So these people also have a lot of glucose secretion in urine, glycosuria, ketonuria, and they can develop a complication we refer to as the DKA, or diabetes ketoacidosis. When they are in that state, they tend to have osmotic diuresis due to the high levels of glucose circulating in the body. They get osmotic, they go into dehydration and lose electrolytes such as potassium and phosphorus and sodium. So they go into hypokalemia. They can develop cerebral edema and they can go into coma.
Okay.
That is now the DKA patient or the diabetic ketoacidotic patient.
That is the first stage.
No, now that is the complicated stage which they present, because most of the time it is not being picked out. Like we said, these are community, the disease is in the community. It is presenting towards the age of 7 years, and most of the time they come at the OPD, outpatient, as a complication. Somebody who's in coma, then you assess them and you find they have elevated glucose, which may be way above 20 millimoles per liter.
So these stages, as far as they may go, is it pretty easy to diagnose this at a very early stage?
Routine screening does help.
Okay.
It does help. And then if there is a family history, it also does help as to know that for the young people, we have got something called the maturity onset diabetes of the young or the youth, which has a 3-generation family history of diabetes. And then when you assess them, you find that they're actually developing diabetes. So that is possible to tell and predict based on the family history of diabetes. And if they are twins, you can still tell that the other twin has a higher chance of developing the same symptoms.
Oh.
Yeah.
All right. Well, so this is type 1. Type 2. How can then we get to type 2, or which is the most dangerous of the types?
Both of them are dangerous if not well managed, because type 2 diabetes, again.
So type 1 is mellitus, or
is juvenile onset and complete lack of insulin.
Okay.
It is the insulin deficiency type of diabetes.
Type 2.
Type 2 is where we have insulin resistance and less insulin production.
Okay.
Meaning that there is still some insulin in the body, but you need a stimulus for the insulin to be able to activate and stimulate glucose metabolism.
Okay.
So type 2 is becoming more and more common because it's associated with obesity. It's associated with something we call metabolic syndrome, hyperlipidemia or dyslipidemia. People who have got glucose intolerance, as well as these are people who have a BMI way above 25. So we are seeing it in people with sedentary lifestyle, which is becoming quite common because nearly everybody now is driving, and if they are not driving, they ride a motorbike. There is less exercise. Exercise, by exercise we mean isometric exercises like brisk walking, jogging, swimming, riding a bicycle to work. Few people are doing that. Majority of our people prefer to sit in their offices for hours. They like taking high-calorie diet. High-calorie diet includes things that contain high levels of refined sugars like sucrose. Things like ice cream, chocolate, cakes. People like sweet things. We eat taste. So the tastier the food,
more dangerous,
the more likelihood that you are consuming high-calorie diet. And then when you take such high doses of high-calorie diet, the liver, at the blush border in your stomach and in the lining of your intestines, there is an enzyme that is supposed to convert glucose to sucrose, or to break down complex sugars to simple sugars for them to be absorbed. So when you are presenting it with simple sugars or refined sugars, it becomes very easy for that to be absorbed, increases the load of glucose circulating in your body, and in the end, you end up having type 2 diabetes.
Oh, how dangerous are the natural sugars? Say honey, some foods that are naturally sweet, sugary and all that. Is there anything wrong with that? Would that trigger?
We don't worry so much about fruits because that is not what most people take. People prefer drinks that have high sugar, sucrose content. In fact, the only fruit we would be concerned is sugar cane, because it has sucrose. But the other fruits are generally recommended because they contain other essential vitamins which help to reduce the complications that will occur with a poorly controlled diabetes. So type 2 is more common, it is increasing, and we are seeing more obesity, we are seeing more sedentary lifestyles, and more parties. People hold parties and eat sugary things. And I think that's where we are.
Okay. All right. There's someone who writes here, Griffith Balani says, I am diabetic. Dieting is the best way to manage diabetes.
Yes. If you have type 2 diabetes, usually we have diet by prescription.
Right.
Whereby we would want them to purely take what we refer to as complex sugars, which take time to be digested and to be broken down into simple sugars which will be absorbed in the body. So we are delaying the amount of glucose that will end up in the bloodstream. And some of these foods, we used to take them when we were young. Our grandmothers and grandfathers used to take them. Things like cassava, yams, millet, sorghum. You see, these are traditional foods, and they contain complex sugars, but they have to be broken by an enzyme which we call alpha glucosidase. So when we have a patient who is not willing to take those that diet by prescription, sometimes we have to give them medication that inhibits the alpha glucosidase inhibitors, so that they stop breaking down or hydrolysis of the complex sugar to simple sugar for absorption. So there is medication for that. An example is acarbose, but we also have other drugs which we use to manage type 2 diabetes by enhancing the sensitivity of insulin in the muscle, in the skeletal muscle.
Okay. Yeah. All right. Now, another person is asking, just what will it take? I mean, or what is this that triggers for one to get diabetes? What are some of the things that we need to avoid that automatically will get us to a moment where we are free and we will not have to fear or worry about getting diabetes?
I think we are already talking about that, because one of it is diet.
Yeah.
We have to have diet hygiene and try to do
exercise.
Especially the exercise I'm talking about is not isometric exercise. I mean, it's not isotonic, it's isometric. Because isotonic exercises include weightlifting, and that is not recommended for diabetics. We recommend jogging, brisk walking, swimming, riding a bicycle. And these are not quite common because people prefer to drive all the way to work.
Yeah.
People prefer to ride a motorbike all the way to the market. In the past, people used to walk to the marketplaces in rural areas. Now they're always making a phone call, because we are able to communicate by mobile, to call the boda rider. So people rarely walk. As a result, they are gaining weight. People are also becoming more, they love partying and so many things that go with party after party. So those are the things we are telling people to have some level of discipline. It's not bad to hold parties, but if you are eating cakes week in, week out, there is a high likelihood that you are developing, increasing the sucrose levels, high load of sucrose, which is a refined sugar. Yeah. Eventually you turn out to be a type 2. Diabetes. So
the first one is hereditary, you'd say?
Yeah, the first one I have said is a T-cell mediated autoimmune reaction. Okay. Type 2 is the one that we think there is a genetic predisposition.
Okay.
We think there is a genetic predisposition to it. There are some alleles and some HLA antigens that we associate with some of these diabetics. So there is a family history again.
And so in such a case, you can't run away from it.
Yeah, you will find that you can run away from it by dieting, by exercising, avoiding those highly, refined sugars.
What are the chances?
Many people, in the past, we never used to have diabetics in neighborhoods, in rural areas.
Yeah.
You would find one case maybe after going for 10 or 20 kilometers. Today, you are finding a case in every other household, especially in areas where people consume high-calorie diet. And if you look at our dieting, we take a lot of ugari, white flour. White flour is also going to give us a high load of glucose. We take it in the long time of the day, because we take that just before we go to sleep. So we are not exercising at night. Most of the time, it will be converted into the liver will convert it into fat and glycogen and store it in the body. And then at some point, the body is unable to cope with the amount that you are delivering.
Yeah.
So people gain weight. They have trunk obesity, where you find a lot of fat has been deposited here in the tummy. They have visceral obesity. Some of it is deposited on top of the heart, the kidney. Then they start having problems with their blood vessels, high blood pressure sets in. So you can see all these kind of complications, and we are seeing them increasing at an alarming rate.
Well, of course, you'd want to know what then are the signs and symptoms, because sometimes, well, we're just having difficulties, you know, and a majority of things that we choose not to seek medical help, that the stages get to, you know, levels we can't control, or levels we can control, but, you know, are a bit with a lot of damage already done. So how do you get to know that these are signs and symptoms of diabetes, or what do you do to make sure that, you know, if you're experiencing uncomfortable moments, then you proceed to hospital and, of course, seek to get diagnosed? And what is it that you expect the moment you hit the hospital and you are being taken through the processes of understanding whether you have diabetes or not? We learn of all this after this short break.